And welcome to the Dr. Bob Show. We'll be spending most of this show talking about a problem that's very, very common, more common than you think, sometimes very, very embarrassing, more embarrassing than you think. We'll be talking about female urinary incontinence. Do you know that there are different types, there are different treatments, there's different things that you can do? We'll be learning about all those facts on this show. My guest is Dr. Katherine Cameron. Dr. Cameron is a board-certified urologist. She deals with these questions and these problems every single day. She'll be teaching us on how to solve the problems. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about, is there a cure for sinus disease? And if so, what is it? And how do you recognize depression, or maybe it's not really depression? What would it be? A lot of information for you. You're going to want to stay tuned. We're talking with Dr. Katherine Cameron, board-certified urologist, and we're talking about female urinary incontinence. Katherine, welcome to the Dr. Bob Show.
Thank you for having me.
How common is incontinence? Is that the same thing as leakage? What is incontinence and how common?
It is extremely common, and urinary incontinence, yes, is the involuntary or accidental loss of urine.
Are there different causes?
Yes, there are. There are multiple different types. The most common types that we're generally dealing with are one of three. One is stress urinary incontinence, which is incontinence associated with increases in abdominal pressure.
What causes increased abdominal pressure?
That would be like coughing, sneezing, laughing, jumping on the trampoline, jumping up and down.
All those things can cause stress on the urinary
bladder,
tract,
the urethra.
And you have leakage.
Correct.
That's stress incontinence.
That's stress. Urge urinary incontinence is incontinence associated with the sudden onset of urge to go void or go to the bathroom.
Which is worse?
They can be the same. In fact, I ask my patients that. If they have mixed, which would be our third type, which is both, which is more problematic? Sometimes it's one or the other, and sometimes they're equally as bad.
Is the treatment for both stress or urge incontinence, is one easier, or it depends on the patient? Everybody's different.
It depends on the patient. Everybody is different. There are similar treatments for both that are fairly conservative that you can sort of apply to anybody, no matter what kind of incontinence there is.
So let's go back to stress incontinence. That's when somebody's laughing, coughing. How do we approach that? What do you hear on the history? How do you, in your mind, say, oh, this is very common, stress incontinence, I know what I'm going to do? Well, guide me.
So the classic history that a patient will complain, or the chief complaint, would be, I leak when I go run, or I leak when I'm jumping on the trampoline with my kids, or every time I cough or sneeze, I leak. And then there is the absence of needing to go to the bathroom too often or urgently. And so they don't have that. That would be pure stress urinary incontinence.
Is that easy to treat, hard to treat?
Sure, well, there's lots of treatment options, but yes, there are definitely good treatment options. And there's the run the gamut of Kegel exercises, weight loss, and then all the way to surgery.
Do all those help? Certain kind of exercises, losing weight, does that help?
Yes, in fact, that's a great example of a little bit goes a long way. So there's a statistic that if you lose 10% of your body weight, that translates to 50% reduction in incontinent episodes.
Whoa, so that's really, really important to say, we got to talk about your weight, because if you want this to get better, part of the treatment is going to be losing weight.
Correct.
Tell me about the female urethra. How long is it? Because isn't that one of the problems? It's so short that it's easy to get leakage?
Correct, compared to men.
Yes.
So that's why women more commonly have incontinence. And so the female urethra, that's the tube we pee through, is only about 4 centimeters long.
So we've got the kidney, then we've got the ureter, the big tube that goes into the bladder, and then out of the bladder comes the urethra.
Correct.
And it's about how many centimeters?
About 4.
4 centimeters. So that's a little over 1.5 inches, something
Correct.
like that. So if the anatomy is bad in that area, it allows people to have incontinence.
Correct.
When somebody is having stress incontinence, what is the basic treatment that you're going to do?
So the first thing we'll talk about is Kegels. Are they doing them, and do they know how?
What is a Kegel, and how do you do it?
So a Kegel exercise, very good question. A Kegel exercise is, I had one of my patients called it her pucker muscle, but it's when you start to pee, you can contract your pelvic floor muscle and cut your stream off. Now that would be to find the muscle, but not necessarily to do it. But that's the muscle you would exercise to strengthen your pelvic floor muscles. It is a skeletal muscle, so you can control it.
So how do you know how to do that? How to find it? How to, do you have to start while you're urinating? You have to start stopping the flow, and then you realize what kind of pressure you're trying to put down?
Exactly, but I don't want people to move all around. I just want them to raise their pelvic floor. So we will talk about that. I have instruction sheets. And then that's one of the classic ways I teach patients is when you start to pee, try to cut your stream off. That's the muscle you're going to exercise. We actually have pelvic floor physical therapy, which is very underutilized. And they, for patients that can't figure it out, don't know how to control it,
sure.
They can train those patients.
Can you tell if somebody's doing Kegel properly?
Yes, you can on exam.
Okay, and so if you're examining the area around the urethra, you can see if the muscles tighten up or squeeze down on the urethra to keep the incontinence.
Correct.
Now, if I'm running, and if I run and I was a female, and that would cause some incontinence, how can you run and do Kegel at the same time?
You can't do that. I mean, that would be hard. You can try to contract it a little bit, but you want to do the exercises ahead of time so you build up the muscle just as if you were building up your bicep muscle so that it's stronger for when you are running.
So you're increasing tone that stays there for all the time,
Correct.
Not just when you're wanting to use it.
Correct.
Is it pretty easy to do?
Yes, Kegel exercises are very easy to do.
Do you have videos on people? Do you have certain positions? I was actually cheating and looking on the video of how to do a Kegel, and there were different body positions that people would be.
Yeah, so you can do lots of different ways of Kegels. We actually teach people most of the time 2 different kinds. We call them the flicker, so when you just squeeze and release them. And then you have the squeeze and hold. And so those are more your endurance muscle fibers that you're working on for maybe when you're running long distance. For patients that really can't do it, that's where we will do the pelvic floor physical therapy. And those are expert subspecialty physical therapists. And they can even do biofeedback and muscle retraining to teach that if a patient is sort of struggling to get it down on their own.
I think that's phenomenal. Is it effective?
Yes.
Does it work?
It does work, and in fact, it's way underutilized. I had a patient the other day who had been through a whole lot of treatments, a lot of tests, and when we finally got her to physical therapy, that is what cured her.
Is it easy for people to tighten down, squeeze the pelvic muscle? As I think about it, I just squeeze the whole area, but can they isolate the muscles that are used
the
around
pelvic
the
floor
urethra?
muscles are sort of a continuous pelvic floor musculature, so you can isolate just that set of muscles to exercise. So yes, and so that's one of the things that we teach.
You also weight loss. Have you got a special way to encourage people to lose weight? Eat less, be more active?
Yeah,
that's basically what it is.
Yeah, simple formula. Expend more calories than you take in.
Yeah,
and we talk about making good, healthy dietary choices.
How about types of food that we eat? Does that have to go with stress incontinence, or would that be more with urge incontinence?
Typically, we think of more urge incontinence. Caffeine is the big player. Caffeine, we know, is a bladder irritant, and it can give frequency and urgency and bladder spasms.
So caffeine is one thing that we're going to teach people that have urge incontinence. That's what we're going to be talking about when we come back. So there are exercises. If you're having stress incontinence, which is very common, if you laugh, if you cough, if you run, if you bounce, and you get incontinence, know that we can work on the muscles and lose weight, and you'll have half of the battle won. We're going to be talking about urge incontinence when you have that sudden urge that you know you may have leakage, what we can do about that. We're talking with Dr. Katherine Cameron, board-certified urologist, and we're talking about female urinary incontinence. We're talking about stress incontinence when you laugh, when you cough, when you strain down. You get some leakage of urine. We could lose weight that really helps, and we can do pelvic exercises called Kegel, K-E-G-E-L exercises. Google that, look at it, talk to your doctor about it, and see if you can get that stress incontinence fixed. And now we're going to talk more about urge incontinence, because people get a sudden urge, I guess. Is that what it is?
That's correct.
How bad can it be if you've got urge incontinence and do you just pee a little bit, or do you sometimes gush?
All of the above, and it can be very embarrassing. So you can have some that can just barely make it and might dribble before they get there. And then I've had patients that have been in Walmart and lost their whole bladder, and they will say, I do not leak, I gush.
And so when a patient says that, do you say, there are things that we can do, don't worry about it, let's get started?
That's right.
So what are some of the things that will stimulate the bladder to have the urge that you're going to have to urinate?
So caffeine is a notorious bladder irritant, and it
So
can
Cokes?
give you Cokes, tea, coffee,
All of those.
even
Chocolate?
even chocolate, yes.
I always
chocolate.
tell people in allergy, I never make anybody allergic to chocolate.
Chocolate.
So all of those can cause urge incontinence.
Correct. Constipation is another common non-urologic issue because the same nerves that stimulate the bladder stimulate the bowel and vice versa. So if your body is sending a signal to move your bowel or constipation, your bladder will get that same input, and you can get frequency and urgency and even urge incontinence.
Is that more difficult on the patient if you're having constipation versus guiding what you eat and staying away from caffeine, that sort of thing?
It is, but patients don't make that association a lot of times.
Yeah.
And so you have to sort of lead them down to realize that may be an issue, and getting with their GI doctor or their primary care doctor to get that under better control.
So we control the GI tract, we control what we take in, we lose weight. How about those Kegel exercises?
They work for urge incontinence too. You can do bladder retraining with Kegels. So when you get that urge, the natural instinct is to jump up and run. But when you do that, you increase your abdominal pressure. So when you're getting a bladder spasm, you just encourage the leakage. So what we try to teach people, sit there, do your Kegels, and try to abort that urge. Then you get up and go.
So if you've got a patient that's having trouble, when you teach them what we've talked about, how successful is it? Can you really change the life of somebody by this?
You can, and again, for patients that are having trouble, we use our pelvic floor physical therapist for that as well. There are obviously people that don't respond to that. It's not 100% effective. So the good news is we've got other stuff for that as well.
I think that's marvelous. We were talking earlier about a urethral sling, a mini sling. What is a sling? What does it do? How does it help? How difficult is it?
So a mid-urethral sling is for stress incontinence, and so that's supporting the urethra for that weakness and for when there's increases in abdominal pressure. It's easy to do. It is a surgery. It's outpatient surgery. It takes usually about 30 minutes to do, so it's very easy to do.
Results good?
Great. 85 to 90% success.
Wow, so that's really, really good. Do you sometimes, a patient that doesn't do a good job on Kegel exercises just doesn't sit down and do their work? Is that when the sling is most effective, or the use of Kegel exercises plus a mid-urethral sling?
I tell my patients that I do slings on that have failed Kegels or other conservative options, they need to forever and ever and ever and ever and ever do their Kegels even after, because it again is a skeletal muscle, and if it gets weak, it can come back.
I think that you have taught me so much already about this, because I really didn't know how successful just contracting the pelvic floor muscles would be as far as that goes. What other type of treatment is there? And do you isolate mainly the stress or the urge? Most people have mixture, so how do we develop further and further treatment?
So we've talked some about the stress incontinence treatments, and the mainstay would be what we've talked about, the weight loss, the Kegels, and then if we get to, we have surgical correction. So for urge incontinence, Most people have heard about the medicines, and there are a lot of medicines.
Are they good? Do they help?
They're good and they help. However, they have side effects, and then the disease process can progress and they stop working. And so we don't want patients to lose heart, because now we have really great advanced third-line therapies for patients that have refractory urge incontinence.
So what would be third-line treatment for refractory, people that weren't doing well?
So we have three main third-line therapies. One would be Botox, where we look in the bladder and inject Botox.
Botox
Yes.
in the bladder?
It was approved in 2013 for the refractory overactive bladder.
So what does it do? Relaxes the muscle?
Correct.
It's a skeletal muscle?
The bladder muscle is a smooth muscle.
Yeah. So it relaxes the smooth muscle also?
Correct.
And is it easy to inject
It is
Botox?
very easy to inject. We have a specialized needle, and it takes about 5 minutes to inject Botox in the bladder. We do tend to do it under twilight, so a little bit more comfortable.
Yeah. Just, by twilight, you mean a little bit of la-la land
You got
anesthesia.
it. You got it.
So Botox, what else?
So we have posterior tibial neuro stimulation, which I tell patients is the acupuncture. We have a little needle, we put a little needle in the ankle where the posterior tibial nerve runs, and you can stimulate that nerve for 30 minutes once a week for 12 weeks, and it actually has a 65% improvement in urge incontinence.
Oh my goodness. Botox, stimulation of nerve way down in the ankle. Can you set up a wire that automatically you push a button and stimulates it?
No, one of our nurses puts in the needle, and then it's on and it stimulates it for 30 minutes.
How do you decide which one to use, Botox or the nerve stimulation?
We have a conversation with the patient. We talk about the goods and bads and uglies of all of our options, including the third, which is the interstim, or it's the sacral neuromodulation, which everybody kind of knows as the bladder pacemaker.
Okay, so it's a bladder pacemaker.
Correct.
And how do you do that?
So
you have to go in the back
that
where the
goes in the
sacral
back.
spine is?
Correct. So the sacral nerve root is what stimulates the bladder. Specifically, we're looking for the S3 nerve root. So when we stimulate that, then it puts the bladder back in the normal functioning.
So when you stimulate the S3, the third sacral nerve, or space area, how do you know you're there? How successful is it? And then I'm going to ask you how you know whether to use the Botox, what I call the ankle stimulation, or the back stimulation.
So
Everybody's different.
So the interstim is very successful. It has about 80 to 85% success rate. We know we're in the right nerve root because when we actually put it in, we use fluoro, which is an X-ray, to find the right landmarks. And then there are specific motor responses to that nerve to say we're in the right spot. So that is how we sort of decide we're in the right spot for that. How we decide between those three, it is a conversation between me and the patient. I explain what is involved with each, the goods, what is good about it, the bads, and then we sort of make a combined decision on what we think would be best for them.
Katherine, this blows my mind, the number of options that you have for a very serious, significant problem that embarrasses and bothers people socially, physically, and everything that they do. They've got to guide themselves. And here you've got all, do most people know that all this is, I certainly didn't.
No. And most people think it's still a part of aging, that they just have to deal with it, but they don't. We have lots and lots of good options, tools in our tool chest to treat it.
Do you ever get a patient that says, well, I'm trying to lose weight and I'm doing the Kegel exercises a little bit, I'm just tired of all this. Yeah, how do you encourage them to keep it up?
Well, we talk about it. I mean, I certainly have said, I don't want to lose weight, I'm not going to lose weight, and then we do the sling. I mean, some patients, so you really tailor it to the patient and treat each patient individually.
You're so fun to talk with about this problem, you know, that has a real, what I call cure available for people if they simply take the time to go to the doctor, discuss it, keep going back and say, I'm not well yet, I still had this problem at this time. Katherine, thank you for coming to the Dr. Bob Show. You're a great teacher with a great problem with a great success rate.
Thank you so much for having me.
Boy, that's absolutely fabulous. You're going to want to stay tuned. We're going to be talking about depression. You know, there are other illnesses that can mimic depression. We'll find out what some of those are. And is there a cure for sinus? There are things we can certainly do. You'll want to stay tuned. I want to thank Dr. Katherine Cameron. Wonderful discussion on female urinary incontinence. I really learned a lot listening to her. Now, from questions from you, the viewer, that I think will be important to your health. Question number 1, Dr. Bob, how do I recognize or really know if I have depression? That's a very insightful and interesting question. Depression, people are in the blues. They have no interest or excitement in anything. They don't feel good. They wake up with the blues. They go to bed with the blues. They lose their interest in things that are normally fun and make us happy. There are illnesses that can make somebody think they might have depression. Thyroid disease, endocrine disease. Somebody that's got an underactive thyroid is sluggish, they're slow, they don't feel good. And somebody that's got an overactive thyroid, they're overactive, they don't sleep well, they get tired, they get depressed. So that's one of the things that can cause depression. Medications. Some people are on pain medications. They're on pain medications so often that the pain medications will have abnormal side effects and make people sort of feel depressed and lose interest in things. They're always hurting. They've always got pain. So those two things that can mimic or make us think that we have depression. Other things might be a sleep disorder. If people have restless leg syndrome, or they snore, the other person snores, or they've got obstructive sleep apnea and they're waking up several times an hour not even knowing it. They're tired, they don't perform well, they don't have energy, they feel sort of depressed. There are some other illnesses in the brain that cause problems like Parkinson's disease, like dementia. And they can hide and mimic depression, make people not feel well, not performing well from a central nervous system standpoint. So if somebody thinks you've got depression, look for that. It's a very serious problem. But be sure that the doctor you see entertains the other possibilities that can be hiding or mimicking or make the wrong diagnosis of depression. So get on the right track, get on the right medications, take care of the problems, and see if that doesn't make your life better. Question number 2. Dr. Bob, how can I cure sinus disease? Well, that's a good question. Let's talk about sinus disease. The sinuses are holes in the head that drain into the nose. The nose has two sides, right and left. There's a septum that divides the two compartments, and on the inside of each compartment there are what we call turbinates, and they're little round marbles or mini marbles, and they're there for surface area. They provide moisture and warmth. So the purpose of breathing in air through the nose is to send warm, moist air to the lungs. If something goes wrong there, we can develop sinus disease, sinus infections. What can go wrong? Well, a crooked nose can deform the way the air goes through the nose. If somebody has turbinates that are enlarged, then it doesn't give enough air to pass through that area. If somebody gets infected on one side, then that can also make it to where people have chronic sinus disease. The sinuses usually drain into an area called, medical name, osteomial unit. We have to get a CT scan to see if the osteomial unit is open to where the sinuses can drain. And then we need to look if there's underlying allergies or if you've got a sensitive nose to pollution and changes in temperature. And all of these things can cause abnormalities in the nose. They're all treatable. There are excellent medications for that. We can straighten up the nose. We can open up the osteomial units. We can shrink the size of the turbinates. We can treat with medications appropriate to where the airflow through the nose will be better. So it frequently takes getting x-rays or good examination by an ear, nose, and throat doctor or an allergist to do skin testing to find if underlying allergies are making the nose swell, or if the nose is crooked and the airflow pattern is not good in the nose. All of those things are correctable. Sometimes people get a runny nose after eating. That's called after eating runny nose, post-gustatory rhinitis. And there are sprays that can block the 10th cranial nerve that sends the messages to the nose after we eat. So almost all nose problems are treatable, and they're treatable with good medications. So be sure if you've got stuffy nose, congestion, drainage, blocked head, don't feel good, headaches, pressure, recurrent infections, that you see your doctor and you get on the right track to improve the sinus health. It's all the time that we have for this show. I hope you've enjoyed it as much as I have. Remember, the 4 things that we like. Number 1, exercise. Why exercise? Probably the most important thing we can do. Takes care of stress, helps the heart, lowers the blood pressure, makes us feel better, makes it where we can sleep better. Get 7.5 hours of sleep. So many times people have something that interferes with their sleep. Either somebody is snoring, maybe obstructive sleep apnea, maybe restless leg syndrome. Maybe people get to sleep, wake up, can't go back to sleep. Maybe pain, maybe medications are keeping them from sleeping well. If you're not sleeping well, talk it over with your doctor. Eat properly. I think we're really marketed to eat a lot of fried fatty foods. Eat good foods, fruits and vegetables in smaller volumes. And when you do that, you'll find you're in good shape. And most of all, what is it we like? It's that laughter in your life. Laugh a lot, have fun, and you'll stay healthy.